for today's webinar on palliative care, it is my pleasure to introduce our guest speaker, Della Roberts. Della, if you want to give everybody a wave, thank you. So Della is the Special Projects Manager with the BC Centre for Palliative Care. Della has over 25 years of experience as a palliative care and end-of-life care leader, and she's also a clinical nurse specialist and adjunct professor at the UVic School of Nursing. And so I would like to give a very warm welcome to Della, and thank you so much for being here to tell us a little bit more about what is palliative care.
Thank you very much. I really appreciate the invitation to join the circle today from the Alzheimer's Society of BC. So as Kimberly mentioned, I'm a registered nurse and a clinical nurse specialist in palliative care, and I'm going to share some of my understandings from many people that I have had the privilege to walk alongside over the probably more than 30 years I've been involved with palliative care. But I'm also here as I'm a daughter and a sister, I'm a wife and a mother and a grandmother, and I'll be drawing from my understandings of my own experience as a family caregiver for some people who also live with dementia. Kimberly mentioned that I've now work with the BC Centre for Palliative Care, and I'm really pleased to be involved with this not-for-profit organization that really focuses on supporting the vision of people with serious illness and those around them to live well, and to support compassionate communities and communities that recognize that loss and grief and death, bereavement, illness is a natural, normal part of life, and that we need compassion within our communities to hold each other up. And the BC Centre works with healthcare providers as well as community organizations towards that goal. And these are what I've kind of framed the presentation around. But I want to start by talking about, well, what is palliative care, and why for people living with dementia, or those people supporting someone living with dementia and influenced by it, why is it relevant to us? And so just to start us off, palliative care is really an approach rather than a place. We'll talk more about that. It's a philosophy and an approach to care. And it's really grounded in this knowing that it's focused on quality of living, like the whole person and their family that lives with serious illness, lives with dementia. But with a knowing that palliative care has a great role to play for people that have advancing illness that will end their life. And we know that dementia is a progressive illness. And if someone doesn't die from old age or from other kinds of things, that dementia is progressive with different kind of paths. And palliative care is oriented to that, to focus on living well now, but also preparing for change and tailoring to each person and their family. I would say there's not a generic palliative care. We'll explore that a little bit more and describe more about, well, what does whole person care mean to you? What does it mean to us? And I want to start by telling you my story, because we could have anybody share in our circle today, but it's helpful to understand kind of a story of why does it make a difference. So my mom was a very healthy, active woman, and was diagnosed with frontal lobe dementia when she was only a few years older than I am now, actually. And we focused very hard as a family to focus on her abilities, focused on living well, and I think that that we were able to do that. What we didn't know, and we weren't provided with any information about, and we didn't seek this information either, was that with frontal lobe dementia, people can lose, and often do lose, their ability to verbalize much earlier than they lose their ability to function, just be in other ways in life. So with my mom, we were very focused on enjoying life, living well, maximizing all of the time that we had with her, and her um, those things that she could do still really well. And what we didn't do was talk to her about her hopes, her worries, her wishes. And we never had that opportunity because that ability that mom had to communicate, that was lost before we realized. And we never did speak to her about that. And it is a regret of mine. And it's something that really informed a really different path with my sister, who is now a similar age to what mom was, and she's living with us, and she has frontal lobe dementia. And we have had really full conversations to know what her hopes, wishes, and worries were. And it's so important because now she doesn't have that ability to communicate that to us. So to be grounded and know that actually how we're focusing in life is what is quality and what that person would want. And guidance, that guidance is a foundation of palliative care. It's one of the cornerstones of palliative care. I'm going to show you a little video here. I'm going to actually stop my share, and Kimberly's going to share. And it's from Pallium Canada. And it talks a little bit more about this concept of palliative care and early palliative care. So let's stop together and listen to this video clip.
What comes to your mind when you hear or see the word palliative? Many people, appropriately, think of words such as compassion, dignity, or quality of life. However, for many people, what comes immediately to mind are the words dying, terminal, and end of life. Unfortunately, too few people think of palliative care alongside treatments to control the disease.
I'm Dr. Gordon Giddings. I'm a palliative physician at the University of Ottawa and clinical content editor of Pallium Canada. The aim of this Pallium Doodle is to explain that palliative care is not something for just the last days or weeks of life, but should be initiated much earlier.
To better understand this, let's look at the illness trajectory, starting at the time of diagnosis of a life-threatening illness. In some cases, the disease, whether it be cancer or another non-cancer disease, can be cured with treatments. In other cases, however, the disease may be incurable. Let's draw a graph around this journey. On the x-axis is the length of that journey from diagnosis to death. On the y-axis is the goals of care, the treatment and care options in focus. Now, unfortunately, because people often think of palliative care only for the last days or weeks of life, they will only activate a palliative care approach in the last days or weeks of life. Let's look at the negative consequences of this. They include lack of symptom control with unnecessary suffering, inappropriate treatment choices, prolonged psychological distress because no one is addressing the fears and concerns of the patient, lack of discussions about prognosis, or lack of preparation regarding care choices and treatment goals. So what do we need to do? Well, we need to erase the old model of palliative care and use a different model, a different approach. What if we start palliating early in the illness? This does not mean that treatments to control or cure the disease and palliation and supportive care are mutually exclusive. The model of early palliative care is much more patient-centered and responsive to patient needs. Is there evidence to show that early palliative care is better than late palliative care? In a large U.S.-based study by Timmel and colleagues, the model of early palliative care was compared to the usual or common model of palliative care, only in the late phase of disease. What do you think the results were? Which group do you think did better? Which group had less depression and less anxiety? Which group had better quality of life and symptom control throughout their illness? Which group do you think lived longer? The early palliative care group experienced significantly less depression and anxiety, better quality of life, better symptom control, and astoundingly, They lived almost 3 months longer than those patients who received only late palliative care. So the key message is palliative care early is better than palliative care late.
So the notion, and I really liked a couple of things that I was able to glimpse in the chat. We had support, but did we have palliative care? What are the signs that someone's even in need of palliative care? So we can have care. I would say my mom had care. We had home support workers coming in. We had, she was connected with a geriatric specialist. We had care. People were monitoring just how are things going with her. But we weren't having palliative care foundations, which is a focus on what's most important to the person, their wishes and their values. So we didn't have somebody exploring that. The experience, their body, mind, heart, and spirit. Now, palliative care is not about coming from a person or being referred to a service. It is a philosophy and care that can be delivered by anybody and that we can ask for. We also can ask for this care. So, for example, looking after somebody's body, mind, and spirit might be a question, this question that I posed there, coming from myself. What do others need to know about me and my culture to provide the best possible care? Because each of us is different. What would take care of us, meet our needs? We can't assume that what would be important to me is what's important to my father. It also needs to be grounded in the person's situation. Do you live in a really remote area? There are people calling from all over the province. Now, maybe somebody lives in a community and their family all lives elsewhere. Maybe somebody is living with their family. Maybe there's lots of community resources, strong circle of support. Maybe a person is isolated, and we know that isolation, being isolated and not having support and belonging has worse outcomes for people. Those people their condition will decline much sooner than those that have that strong circle of support around them. And what is the condition? So we maybe all commonly hear because we're interested in supporting people with dementia, but there's many kinds of dementia and many people have multiple mixed kinds. So we do need to know for each person what's the expected course so that we can explore treatment options appropriate to that individual. And then what services are available and what are their criteria? So being identified as palliative is often relates to certain services, and I'll talk a little bit about that as we go through. So I wanted to just explore with you, first of all, the importance of knowing your condition and the expected course. Sometimes I've met people and they said, well, I've been told I have dementia, but not what type of dementia. Maybe you have multiple kinds of contributing dementias, but that should be described. So when my dad was diagnosed with dementia recently, and the doctor told him that he from his test had dementia, my dad just shook his head because he was thinking about my mom's frontal lobe dementia, and his experience is very different from hers. And so we talked about it, about what was his condition and what was expected with his condition, because it was different than my mom's. May also have many of us just condition or illness, maybe have heart, lung, renal disease, other kinds of things that also have expected courses related to that, or types of cancer. So this is the kind of question that needs to be answered by your healthcare providers. You can't necessarily Google all this stuff. What is it about yourself? And often a question that a healthcare provider might ask you is, what do you understand about your illness and what you can expect over time? And I find that oftentimes we're not asked that question when we go into healthcare visits. So I often ask the physician that question. I say, can you explain to us more about either it's my sister or my dad's condition, what we could expect over time? So Alzheimer's disease, I'll just give you a couple of examples. We know that there's short-term memory loss and some language difficulty that happens and problems with planning and organization, typically a gradual progression over many years. Vascular dementia is related to problems with blood flow, and those blood flow problems affecting brain matter, and areas of the brain not functioning well because they haven't had enough blood, which is often related to other diseases connected with blood flow. And in my dad's case, he has a buildup of plaque in his vessels. He's had significant coronary artery disease, and that's happening in his brain as well. And so for him, what we're seeing is kind of stepwise changes in that where before he could tell us stories from the past, he's quite a joker. He can't remember things from the past very well now, and his short-term memory of what happened even earlier today has changed. And that's a real change from about 6 months ago. Often with vascular dementia, you see stepwise changes. With frontal lobe dementia, oftentimes when it's diagnosed, you've had significant dementia evolving, and so the changes can be more quickly over time. So you really have to know what's the underlying condition. When people have heart failure, heart disease, and they've been admitted, somebody has advanced heart disease and they've been admitted to hospital, let's say twice in the last year, we know that many of those people will have a change in the next year, and that change could be a dying time. So they also have a different path. And it's important for us to receive palliative care, to have information about our condition and what we can expect over time, if we're the kind of people that want that. Not everybody wants that. So we have to know what kind of person we are, because everybody has different ways of experiencing life and what's important to them. What I would say as a family caregiver is, if you don't understand what's potentially an expectation over time, maybe the person themselves isn't that interested to hear, but maybe as a family caregiver, it's really important for you to understand so that you can be prepared. Because palliative care is about the person and their family. So I'm just curious, I'm not able to see the chat. Those facing serious illness who are on the call or have a family member facing serious illness, can you just share? Have you had conversations about what is expected with your condition over time? You can put many, if yes, you've had many. If you've had a couple, few, you had one good conversation, or no, you haven't had those conversations with physicians and nurses. Maybe you as a family have talked about it. So if you could put those in the chat, and I'm curious, Kimberly, what kinds of things, if people are starting to put anything in, we're seeing.
So far, several answers are no conversations. One person has said few and one many.
Okay. So one of the takeaways from the session, and at the very end, I'm going to share some specific suggestions around this, but for those of you that have had none or few, if you have a serious illness or your family member has a serious illness, we should have many, because these are conversations. Palliative care is grounded in conversations, because we have to know. And the other extremely important part is we need to know about you as a person. What's important? What are your wishes? What contributes to your well-being? And if you don't ask these questions, you don't know. As a substitute decision maker for my dad, I had made some assumptions from conversations we had before. But now that we're having conversations again, I see that what's important to him has shifted. So these are conversations over time. These advanced care planning conversations about thinking about what matters to you, discussing those with people you trust and your healthcare providers, and then making sure that that's recorded and that there's a plan. Most importantly, for those of us that would have to speak for someone at the point they're not able to speak for themselves, I made an assumption for my dad we were having some treatment decisions, I made an assumption that he might not want some of these cardiac treatment because he might get through that treatment, but then live with more frailty and then maybe need help with bathing, maybe be at risk of going to a nursing home. And so thankfully I asked Dad about it, and he said to me, oh, he said, they probably got TVs in there and lots of people. He said, that's okay with me to have somebody looking after me. He said, what's most important to me is that I'm able to see the people that I love. It's like, oh, I wasn't up to speed about what was important to him. So yes, palliative care can be a part of advanced care planning. I already told you that conversations are a foundation to a palliative approach. And they need to happen. But secondly, palliative care can be identified as a preference. So just to continue on with this example from my dad, he said, enjoying my life is more important than length of life. Well, Dad's 91. My sister, when I talked to her, though, she also told me, even though she's young in my mind, she's 69, she also told me when we had the opportunity to talk about this, that enjoying her life was more important than the length of her life. And so the kinds of things from palliative care around, well, what does quality mean? Being surrounded by family, being able to get out in nature, and enjoying food. So more important to my dad to enjoy foods than have his blood sugars tightly managed. So people might say, oh, that doesn't sound like palliative care. That's what I wasn't thinking palliative care was. Palliative care is about care for the whole person, making sure that they're physically comfortable, emotionally, socially supported, spiritual needs met, living well, and preparing for a change, preparing for death in the future. So what treatments then are included in palliative care? Well, treatments could be, there aren't many treatments that just aren't part of a palliative care continuum. So it's dependent on, first of all, knowing the person, where they're at in their condition, as I talked about. So where along the journey, how advanced is your heart failure? How advanced are changes with your dementia? What are your goals? What is most important? And most of us have goals like this. I mean, I had a huge goal. I had 3 grandchildren that were going to be born this last October, and I had a lot of goals that were focused on seeing those babies born. What is the condition, and what benefits are possible, and how beneficial will the treatment be? So every time somebody with dementia has specifically a surgery, depending on how advanced that dementia is, the surgery, which is itself, can cause a stepwise change in someone's cognitive function, that they might not return to where they were before. So it's very important to look at all of us, to look at ourselves, to be looked at as a whole person. The way we're organized in our healthcare system often are referred to physicians that are looking at one piece of us. And so with vascular dementia, treatments that often might be related are things to deal with underlying artery disease. And so, for example, someone that's had a stroke might have had a clearing of an artery in their neck because it was clogged up and sent a clot up into your brain. And my dad had that, and he benefited from it. They were wanting to do scans and stuff about seeing what the other side was like and whether or not they should be considering that surgery. But my dad's overall, he's not the same person that he was, and his ability to tolerate that and manage well, going for a surgery like that may well mean that he wasn't able to come home. Dad lives at home. He describes himself as, what does he say? Fraying around the edges. But he does well living at home. But he would be at a high risk of having his knee replaced or having some other major surgery that he may decompensate and not be able to do the things that are most important. So the benefits of treatments have to be looked at in relation to the whole person. There is a treatment that is very specific to palliative care, and I want to share a little bit about it with you because oftentimes people don't understand much about it. It's called palliative sedation therapy, and it's really only for a small number of people who during their dying time. And so it's if someone was not comfortable and they were suffering in their last days or few weeks of life, they're on their dying path, they're close to dying. We're very good at treatments to manage pain and shortness of breath, which is those are important parts of palliative care. But if we weren't able to manage somebody's underlying comfort, we could make a decision with their family, if the person couldn't speak for themselves, that the person would be more comfortable just to sleep. That's a very different type of treatment or therapy than medical assistance in dying. And I know you're going to have a session about medical assistance in dying, and that's not the purpose of today, but that's a process where a provider helps a person voluntarily and intentionally end their life, not during their natural dying time. Having someone sleep, intentionally be sedated during last days of life is palliative sedation therapy. So the person is less aware. And I must say that when people die from dementia, my experience is a very peaceful death. As the brain is an organ and is it shutting down, it's a very peaceful way to die. But many people have different experiences, and if someone that wasn't their experience, this is an option. And it's actually nothing that has to be decided in advance. If there was that situation, the physician or nurse practitioner could ask for your verbal consent as family members, and then somebody be provided with sedation. So I wanted to talk about it because it is a palliative therapy, and it's something with the initiation of MAiD, people really have heard about MAiD, but they haven't really necessarily understood about palliative sedation therapy. And as we're talking about this, as I'm talking about people's natural dying time, I also wanted to just highlight that when dementia is very advanced, so that the dying time may be expected, but it may be expected that somebody was going to die, but the timing is very difficult to predict. So a question then is not, do we expect this person to die? The question is would I not be surprised? Are they frail enough that I wouldn't be surprised with a change, that would be their natural dying time? Because when someone's reserves are really depleted, we can't really see the change going on with them, but change is happening. So it's something, if somebody in your circle is very frail, and you wouldn't be surprised if they died, and you have been connected with palliative care, you definitely need to reach out for guidance and help be prepared for that journey. And oftentimes the diagnosis of cancer initiates that, but other types of progressive illness, especially when something might have a very long course, like many, many, many years, this may be something that there's not a signal to. Things are changing, a trigger to start having different conversations. So what's the difference between palliative and hospice care? So hopefully I've described palliative care. And there are palliative specialty services as well. So palliative care is an approach that can be provided by your family doctor, can be provided, a pharmacist can provide components of palliative care by advocating for you because they're concerned that you're still quite short of breath, even though you're on these medications, and maybe you should have something like an opioid for your shortness of breath. It could be something from your home care nurse or your case manager could embed a palliative approach. There are palliative specialty services with palliative specialist physicians and nurses that are available for consultation. And that, I would say, well, when should you have a consult? If you have needs that haven't been managed by the circle around you and you have advancing illness. There are palliative care units and hospice beds, and there's specific criteria for those. So there's some palliative specialty services. There's an approach to care with the term palliative. And then hospice, that term hospice, is also used in a couple of ways. One is hospice is a society throughout BC and all the communities you listed. There will be a not-for-profit organization with support available to anyone facing serious illness that you can call, you can walk in, and there are services for everything from counseling, volunteers, bereavement support, but support with all kinds of things. And there's no barrier to that. You just reach out and connect with Hospice Society if you have a need that you think they could be helpful with. And they are very knowledgeable to point you in the right direction as well. But hospice is also a term for a place of care. So throughout BC, in some communities, there are hospice beds. So beds set aside for people who it's clear they're in their last weeks of life and they're no longer able to manage at home. And there's quite a quick access to get into those beds compared with a wait list for long-term care that you may be familiar with. So hospices are really for people expected and known to be in their last weeks of life. I would say long-term care is not described anywhere with palliative or hospice, but long-term care is a place that does a tremendous amount of palliative care. They look after people right through to the end of their life. And so they embed a palliative approach to their care in long-term care. So actually long-term care is a place where you can receive and expect palliative care. So who can ask for palliative care? You can. There's been some great work done. Hopefully you will have your family doctor will make referral, or somebody else might make referral, but you can also ask for it. And these two physicians, Dr. Shao and Dr. Winemaker, started what was called the waiting room revolution. And there's a link to the podcast, and it's in the references. But it talks about this is a relationship. Healthcare is a relationship. It's not that we are the recipients of healthcare and they are the doers of healthcare, nurses, doctors, and others. We are part of the healthcare relationship experience. And so we can unlock keys to better illness experience. So the first thing they talk about is be prepared. Walk two roads. Hope for the best, but also prepare for different outcomes. So although I'm hoping that my dad just continues to stay stable, and I tell him he's like a cat, we are prepared for different outcomes. We are prepared at the same time for change, even though we're hoping that he continues to live long and well, which is very different than reacting. Our healthcare system is not set up well for reaction, except for in acute changes where emergency departments and hospitals are very important. The next thing is be informed. So when I asked about what could we expect with this over time? How might that affect me both physically? What are the changes I would expect? Emotionally, spiritually, socially? What is this condition I have? What can I expect? So being informed rather than being unaware. And as I said, the person and the family is the unit in palliative care. Not everybody has to have the same level of information depending on who they are and what their preferences are. But make sure that your circle is informed. Know your style. So this is, are you, so that how do you normally cope with things and how do you face challenges so that you can receive care in the way that you like? and then customize the order. Palliative care is individualized care. So what my dad needs for his support, many ingredients are the same as my sister, but she has a different underlying condition, so she needs different things than what my dad needs. That is customizing the care plan to you, your preferences, but also your condition. Expect ripple effects. The family, we're on a parallel journey. And so we also need to be prepared and informed so that we're not feeling overwhelmed. So I think if you're feeling overwhelmed, frustrated, scared, those things on that side, there's something that you need broader from the team, from palliative care. And that first place that you can start with that is having a conversation with your family doctor, having a conversation with the Hospice Society, if you're connected with any care providers. Tag, you're it, play a central role in connecting the dots. I think this is really important for us in healthcare, for all of us, and there's some programs like NAV care programs through hospice societies. Maybe in your circle, everybody's feeling pretty overwhelmed, and that you need an injection of somebody else in your circle to help connect the dots. And then invite yourself, initiate conversations about what's happening now, what's available for you, what you can expect. So I think those are really important, and I'm curious and interested to know what kinds of other questions I could answer for you. That's my email. I'm happy to always answer anybody's questions, and we've got resources. So maybe I will just stop sharing my screen, and then I'll be able to see the chat.
Thanks, Della. That was an excellent presentation, and I know I learned a lot from you today. There's quite a few questions, so I've been doing my best to collect them as they've been coming in, so I can field some to you from earlier in the chat. So there were some questions around if there is any expected cost for the family associated with palliative care.
Now that's a great question. Because palliative care isn't one thing, there's different dimensions. So, for example, going to a hospice bed, there's a similar cost to going to long-term care. Medications. If there's some medications that are covered under a palliative benefits, but those are for medications that really are expected to only be covered for a few months of time. So those are for people on quite a quick trajectory of illness and end of life. Hospice Society services are free of charge. We support our hospice societies to do this good work. So if you require a palliative consult, because let's say you have complex pain or you've got complexity, those are not at any cost because the health authorities cover those charges. So there isn't kind of a generic answer, but palliative care itself is, there isn't a specific extra cost to get it.
Thank you. I think that was helpful. Thank you. There were some questions around the timing, and I think you answered that throughout the presentation, that starting to have those conversations as early as possible. It is not something reserved for the final days or just end of life. So really you can access it as soon as possible, right? Is that what you would recommend?
I think if you've been diagnosed with an illness that you know is going to progress, whether that be dementia or that be a heart or lung or renal disease, then to initiate, like the waiting room revolution, say, initiate the conversation with, can you tell me more about my illness and what I can expect over time? You ask your family physician that you want to have a care planning conversation because they bill differently for it and they set aside time differently. It's hard to if you're booked in and you're getting your medication's renewed, that's not the time, because they've only got a 10 minutes allotted for you. So you say, I would like to come back and have a care planning conversation about my illness and what I can expect over time. And the physician bills differently for that and sets aside different time. What I also would say is, I didn't talk a lot about physical suffering, and emotional suffering, but if you are suffering in relation to your underlying illnesses and as well, you can, again, starting with your family physician or whatever care provider you've got, you identify, I am suffering. I am not comfortable. My pain's not managed. My shortness of breath isn't managed. Yeah. And then they can seek it out. They can refer you. And if you're not getting referred, talk to your hospice society. They'll know of other resources in the community.
I believe on the helpful resources list, we've listed a directory of where you can find your local hospice society to help you reach out. There's a lot of great programs through local hospice societies around grief and loss and to help prepare you for end of life.
And advanced care planning.
Mm-hmm.
Yeah.
Thank you. There was a story shared in the chat about someone's family member, the healthcare provider, kind of really pushed or strongly recommended palliative sedation therapy, although it was against the caregiver's wishes. Is there any advice maybe on how to advocate if that's something, or when does the doctor kind of have maybe the final say on that?
Right. And that's a great question. So palliative sedation therapy only happens in the last days. So what I would say is, whether someone is made to sleep or not, we haven't found that speeds up or slows down their dying time. So sometimes people worry. So a physician may be seeing what they see is distress, that somebody is in a delirium or thrashing around or in severe pain, and they're trying to make them comfortable. So palliative sedation does require consent of the family, but you don't have to worry that if it starts, oh my gosh, it started, and you can still talk to any care provider and say, I'm worried that he doesn't need to be sleeping. And because those medications can be lightened up as well. But there is a reason. It's typically because of pain, shortness of breath, delirium, where somebody is very agitated and not be able to settle. So there has to be a reason to give palliative sedation, but a person is dying. It is not causing their death. They are dying, and palliative sedation helps to achieve some comfort, versus palliative sedation is causing them to die. Palliative sedation is not causing them to die. But in answer to that person's question, yes, you can always question that. And if you felt as a family, no, I don't think that he should just be sleeping all the time, you could say, could I speak to somebody else? I'm not comfortable with this plan of care.
Thank you. There was a comment around, in your experience, do you find that long-term care homes often have the time and resources to provide maybe an early palliative care approach to residents?
Yeah. What I would say is, now the people that get into long-term care compared to like 20 years ago, they're all have advanced disease. It's unless you were admitted to long-term care because of a brain injury or something like that, or a disability, our people are being admitted in very advanced disease. So when you say they're not receiving early palliative care happens before somebody even gets into long-term care. So long-term care is talking about goals of care initially. So are they staffed for care, period? That's a whole different question, the kind of care we would want people to have. But as far as embedding the components of palliative care, sometimes in long-term care, the term palliative, they use it attached to actively dying. Like when the person's starting to actively die, they say they're palliative, but they were palliative way before. So what I would say is the kind of things you can expect in long-term care that they do have staffing funds for is conversations about what can be expected, ensuring that the person's pain or symptoms are managed, that actually their behaviors are not treated just with antipsychotics, that and that they understand what is important to that person and you as a family, and that your wishes are respected. If you have somebody in long-term care that you are worried about their treatment plan, again, you can ask that you would like to have additional access to talk to the social worker, talk to the clinician connected in long-term care, and that you're concerned about the plan of care for their palliative needs. And then think about what need is not being met. Because there isn't like they don't have to call it palliative care to be receiving palliative care.
I think that creates some confusion because of the relationship to us thinking of it as almost as a treatment at end of life, and not something that happens quite early on and can involve conversations.
Involve conversations, because sometimes people think of palliative care as, oh, when they start pain medications during the time someone's dying. Well, oftentimes when people are dying, if they're dying from dementia, it's not painful. They don't necessarily even require they may benefit from something, but it's not necessary. We're made to come in and we're made to go out of this world. It's a natural pathway.
Thank you. There are a few questions around how to access a palliative consultant, if that exists, and maybe who is the best person to go to if you do not have a family doctor, as many people find themselves in that position now.
And that's a huge gap. What I would say is there's a handful of palliative consultants in each health authority. So their role is not to look after everybody who doesn't have a family physician and provide care over time. They have access through other healthcare providers. So again, it's really identifying what is your need. And if it's, for example, pain management, if it's then, and you can still go to a walk-in clinic. A physician at a walk-in clinic could make a referral to a palliative care consultant if he felt or she felt that your need, whatever it was, they couldn't meet. Yeah, so we all have access to walk-in clinics, and walk-in clinics can make referrals if it's appropriate.
And then again, your local hospice society would probably be a good contact as well. Okay, I think that touches on the majority of the questions. Dawn in the chat box has mentioned that there may not be even a walk-in clinic in some regions in BC, which I think would make that more challenging.
Yeah, our access to primary care is really, I really feel for all of us that don't have access to primary care, and it is a big gap, and it's a big gap for palliative care. So it's, we have holes within the system, but I would say probably your hospice society is a really good place to start, because a conversation around what is it that you need, because if it's a conversation about what can I expect with my illness course, maybe it can be a referral to home and community care, and you could have that conversation with one of the case managers or nurses. So really focusing on what the need is.
Thank you. Della has shared her email address. Is it okay if people reach out to you if they have any specific questions? As well, we encourage you to call the dementia helpline if there's dementia support, but I think if it's specific to palliative care, you can reach out to Della.
Leanne or point in the chat that if you have significant healthcare issues, anybody can make a self-referral to home care, right? Anybody can reach out and with the access line for home care and have be able to connect with a healthcare clinician that can help you find your way as well.
Thank you. And you're going to see pop up on the screen the information about our programs and services and how to access the dementia helpline. I do want to just thank you, Della, again for your time and for sharing both your personal story with us as a family caregiver yourself and your professional expertise around palliative care. I know we very much appreciate your time today, and the chat box was very lively, so I think a lot of people got some great content and information from you. So thank you.
Yeah, and I really appreciate everybody's openness and sharing in the chat. And there needs to be a circle. It takes a community for palliative care. So ensure you have a circle of support.
Probably a good time to just shout out our caregiver support groups. When we talk about a circle of support, that's an excellent way to meet other people who are in a similar situation and truly do get what it means to be a family caregiver. And a lot of these topics do come up in discussion throughout those groups. So please reach out to the helpline if that's something that you would like to learn more about. I will wish everybody a wonderful rest of your day. Thank you again for coming and participating. Thanks, everyone.
Thank you. Bye-bye.